I hope that you're doing well. I'd like to welcome you to the webinar, How We Conquered Keratoconus. So very excited to have everybody here. And we're going to cover a lot of topics. And first of all, just want to say welcome to everyone because I know that there's people from all over the United States, from the West Coast, the Midwest, and also from the East Coast and other countries too. And we have a lot of people that are here from all those areas. And you can see this is a map we actually have on our wall in the office with all these pins in different parts of the country, and also from other countries too. So when people fly here or drive over from wherever they're coming from, we always like to have them put a little pin in there. So thank you. This webinar will be about a half an hour or so, and we'll go through things. So let's get started. So first of all, a little bit about me. I'm a keratoconus expert, and I first started with alternatives to cornea transplants, which is what I was doing in the early start of my career back in 1999 when I first started with Intacs. So we actually have the longest experience in the world of performing Intacs for keratoconus. And then shortly after, in 2003, we started doing cornea cross-linking. And we were the first in the United States to do that, and the second in the world to do it outside of Germany. And also we invented the non-invasive epi-on cross-linking called C3-R and later named Holcomb C3-R, which we'll talk about. And I've been an investigator with the FDA for many clinical trials. Also, I've published many journal articles in the medical literature, ranging from keratoconus to LASIK to other procedures and other treatments as well. Presented many lectures over the years. Hard to believe I've been in practice now for about 25 years. And also authored 4 books on keratoconus, the most recent being Fight for Sight. So let's first talk about what is keratoconus. So keratoconus is essentially a hernia. That's the way I describe it because it's a bulge when there's a weakening in the tissue. And like people can get this in their groin, they can get it inside their body, like in the esophagus or other areas. So when we have a weakening of tissue, there's pressure that's inside and it's pushing out against it. And that's essentially why I think of keratoconus as a hernia. And so here's an example. We see that this is a cornea topography map. So that's the way keratoconus is diagnosed. It's this quick picture. I think every eye doctor should have a cornea topography map or some kind of imaging of the cornea. But when we see this, the red is where you can see on that scale on the left side is where it's warmer or hotter colors. That's the bulge. So even if it's like a little bit orange or a little bit yellow, that could be the sign of early keratoconus. Now, the other issue with keratoconus is the top of the actual cornea because it's flat or blue. So keratoconus is really this asymmetry of where it's steep below and flat above. And a lot of people really just kind of pay attention to the steep area, but I'm going to show you the flat is also something that needs to be considered for treatments. So another question I get all the time is what causes keratoconus? So the cause of keratoconus really boils down to not enough of these antioxidant enzymes in the cornea to be able to protect it because the collagen is the structural part. It's like the steel beams of a building. So if the collagen is weak, it can't support the cornea, it bulges out, just like a building is going to tip over if it doesn't have good structural steel beams in the support system. And there are these 2 enzymes, particularly catalase and superoxide dismutase, that are those key ones that are abnormally low in keratoconus. Now, eye rubbing can accelerate it if someone has keratoconus already, and also exposure to the sun because the UV is so intense. That's why we get wrinkles and other damage to the collagen on our skin. Well, guess what? Same thing happens when you have keratoconus and you're not protecting your eyes with sunglasses outside. So, and particularly you want to have sunglasses that wrap around, so they kind of cover around the edges to protect more light out there. And that's the best type of protection versus like a Wayfarer type frame where it's wide open and lets a lot of sun in there. So how do we treat keratoconus? Well, the good news is these treatments that we're going to discuss have been shown over many, many years to be really safe and really effective to help people who have keratoconus, ranging from just the very early stages to even very late stages where doctors may tell people, oh, you have to, get a cornea transplant or just wait for it to get bad enough to get a cornea transplant. So the first procedure is the Holcomb C3-R. That's the non-invasive cross-linking to stabilize the keratoconus. And then the next procedures really are focusing on reshaping the keratoconus to improve vision. So Intacs, and we're going to talk all about these, but I'm giving you the overview. Intacs, and then CARES, which is like a biologic Intacs, and then also conductive keratoplasty, or CK. And by the way, CK is not for Calvin Klein, but for conductive keratoplasty. The Visian ICL lens implant for nearsightedness. And we'll now kind of jump right in. So Holcomb C3-R, and C3-R stands for cornea collagen cross-linking with riboflavin. It's a 30-minute procedure, and as shown here, we apply the riboflavin to the cornea and we treat both eyes at the same time. The reason is because the beauty of it, since it's non-invasive, we can treat both eyes at the same time versus the CXL procedure. Now, Holcomb C3-R now has been for 21 years. We have a long-term stability rate of 99.3%. I always tell people, still not 100%, there's no 100% in medicine, but any procedure with this 99.3% success rate is about as high as you can see in any type of procedure in medicine. It's a 30-minute procedure like we talked about, and it has the longest track record in the world of all types of cross-linking except for Germany. But because we're the inventor of the Epi-on cross-linking, we have the longest experience of non-invasive Epi-on cross-linking in the world. Now, the reason it's named Holcomb C3-R, for people that don't know, is my patient, Stephen Holcomb, was a US bobsled driver, and he was losing his vision from keratoconus, and he was the driver. And his whole dream since he was a child was to win an Olympic gold medal. And when he was losing his vision and everybody's just telling him you have to have a cornea transplant, he became very depressed and actually even tried to commit suicide. And luckily he survived. His team doctor sent him to me. And that's when we did this procedure. At the time, it was called C3-R. And then we also did the Visian ICL to correct his nearsightedness. He actually came out of retirement and then won an Olympic gold medal at the Vancouver Olympics in 2010, and then 2 silvers at the Sochi Olympics in 2014, which was really an unbelievable miracle story. And there was so much media coverage because essentially his story was going from blindness to Olympic gold medalist. We renamed it in his honor, Holcomb C3-R, for Stephen Holcomb. And that was really, really exciting. And I was at the Olympics too with my family. My wife's from Vancouver, so that was really special, especially back in her home city. So now there are some critics, of course, for anything in medicine, right? You have 3 people, you're going to have 3 opinions a lot of times. So, but one of the things that people say is, well, just can't penetrate. You can't get that riboflavin to penetrate through intact epithelium. So like I said, we've been doing this procedure for 21 years. First of all, if it wasn't effective, I wouldn't be doing it. And we know our results, as I said, 99.3%. But here, just to show everyone, we see that yellow riboflavin completely penetrated in the cornea through intact epithelium. This one patient on the left had Intacs. The other patient didn't have Intacs, but we see it penetrates. We've done so many thousands of procedures that our protocol is so established that we know it works, we know it penetrates. There's just no question. And at the end of the day, the results speak for themselves. And also, if it didn't work, we wouldn't have an Olympic gold medal in bobsled. That was the first time in 62 years by Stephen Holcomb. So essentially, there's an Olympic gold medal that actually stands behind this procedure. Now that's in contrast to where the cornea epithelium needs to be scraped off, called CXL. And that's done because the solution that's being used doesn't penetrate intact epithelium. So doctors need to remove the epithelium and scrape off the cornea and top of layer, and that makes a very long recovery and very painful. Now, the way the Holcomb works is there's a concept called cross-linking between the collagen fibers. Imagine this is a cross-section of the cornea with those layers, and those red areas are the links between them. So basically, when we create more cross-linking, we create more stability. It's like reinforcing the weakened beams of a building so it stops tipping. But also, it makes the collagen fibers thicker and stronger as well. So those black fibers you see going horizontally, in fact, get thicker and stronger too. So the indications is keratoconus, keratoconus that occurs after LASIK or PRK, called ectasia, but we look at it still keratoconus, just a different cause. Also, there's people who have radial keratotomy or RK that have unstable corneas. It can help with that. And we also combine Holcomb C3-R with other procedures such as Intacs, CK, and ICL, oftentimes on the same day. But sometimes with ICL, we'll space out that procedure, waiting for the cornea to stabilize 3 months afterwards before we do the ICL. So here's an example of a patient who had 11 years follow-up. She was a 13-year-old girl at the time. And we can just see over those 13 years, the cornea just continues to remain stable from the Holcomb C3-R. That's the right eye. And we see the same with the left eye, 11 years of stability at this patient's left eye. Now, some doctors will tell patients, well, just take a wait and see approach. Let's just wait and see. But here's the problem with that. We know keratoconus is progressive. We know it causes vision loss. And we have a non-invasive procedure that is incredibly effective. It doesn't make sense to take a wait and see approach. And I'm going to show you one patient whose doctor had referred or had recommended that wait and see approach, and you're going to see the tragic results here. So here's the right eye, just showing in pink, the astigmatism is 0.75 diopters. And literally in just a very short period of time, we see that the patient had 2.25 diopters of astigmatism. So that's a really big increase. Actually, here we go. So this is the right eye. This is a year and a half later. So the right eye goes to 4.25 diopters of astigmatism. And that's a very big increase there. And then the other eye goes to 8.75 diopters from 2.25. So that's the problem with taking a wait and see approach, is that the astigmatism can really increase dramatically, and so can the vision loss as well. So at this point, we had to do Intacs on top of the Holcomb C3-R because of the patient giving conflicting, inaccurate information by another eye doctor. And it very easily could have been prevented. So if you have a child and you have keratoconus, it's important to not wait either, because keratoconus can be more aggressive in children too. So Holcomb C3-R can definitely help stabilize that keratoconus before a child even has vision loss, when it's detected early on cornea topography. Now, here's a myth I just wanted to bust, because some doctors will tell their patients that contact lenses will stop the progression of keratoconus, and that's 100% not true. It's no more true than if somebody's head was expanding and they wear a baseball cap. That baseball cap is not going to somehow stop the head from expanding. So just like when the keratoconus is bulging in the cornea, a contact lens that's literally just balancing on the cornea is not going to hold it back. All right, so we mentioned CXL. Let's talk a little more about CXL, the epi-off cross-linking that requires the epithelium to be scraped off. It's invasive, and it's painful, and it has a long recovery. And here's data from the FDA study, and we see that within the first 3 months, 90% of people had some kind of adverse event, which is just another way of saying a complication or side effect. And you can see the list here, going down from corneal opacities, eye pain, dry eyes, light sensitivity, blurred vision, etc. And from a effectiveness point of view, at 1 year, there was almost 29%, 28.5% of people continue to have the keratoconus progress despite going through these side effects and complications. So, and the reason being, in my opinion, is that the light sources that's being used for CXL is a very low amount of light. And we know that the higher the light in the device, the more cross-linking. And also it doesn't treat the whole cornea. It only treats the central, perhaps 7 millimeters of the cornea, for example, depending on what type of device is being used. So it doesn't get out to the periphery. And those combinations, I think, is why we're not seeing the success rate being higher. And that's just at 1 year. And we know typically that more people start to progress year by year after having a treatment. So let's talk about Intacs now. So Intacs are these little micro inserts here. They're made of medical grade plastic. They go underneath the surface of the cornea, and these implants help to flatten. And that's the key, is that they help to flatten. So we place them in a custom way where the bulge is, and it's a typically 7-minute procedure, and typically 1-day recovery as well. And most people never feel them because it's under the surface, just like having a dental filling. They also don't break down, they don't degrade, and they're made of the same material of cataract implants. So we know that they're inert long-term and have really good stability. And actually, my brother-in-law had Intacs 24 years ago. Hard to believe it's that long ago. I was a brunette back then. And my sister-in-law had them 22 years ago. And so they, by the way, still talk to me. So we know that it's certainly good enough for family members. It's good enough for everybody else. And it's really stood the test of time. And they're really effective because they flatten the cornea. They can improve vision. Now, I have to give a little bit of a explanation for, these are just showing some studies that we've published over the years. And this study was actually first published on Intacs 21 years ago. So just to give you a sense, I've been doing this a long time. Like I said, we have more experience, longest experience in the world than anybody. Another study published, another study published. We usually use one segment nowadays than two segments because it gives that custom flattening. And it's a proprietary technique that I've developed, and we treat each cornea individually, even between each patient, because the keratoconus is oftentimes very different from one eye to the next. So we really customize and give the individual expectations for the person based on their degree of keratoconus. So in other words, somebody with mild keratoconus might be able to have an improvement in their vision without glasses or contacts. Someone with a little more keratoconus, perhaps the goal is going to be to help improve their vision with glasses and contacts. So, and the types of contact lenses also depend on the degree of keratoconus when we're starting to evaluate somebody for the first time. Biologic Intacs, or called CARES, is very similar because it's helping to flatten the cornea. This is just showing some of that tissue. It's made of cornea collagen tissue, and it's little strips like this, and almost looks kind of like Intacs for that matter. But it's biologic, and the reason that this can be really helpful is because we can use thicker CARES segments than we can with Intacs. Because just to show you here, here's an example of CARES, the biologic Intacs, if you will, in the cornea. This is a cross section, but they're very thick, and you can't have Intacs be that thick because they'll interfere with nutrient exchange within the cornea. But because this is made of collagen, we can get much more flattening when we need to for more advanced keratoconus with these CARES implants as well. And they take almost the same amount of time. For example, I just did one yesterday. Instead of Intacs being 7 minutes, CARES is maybe 8 or 9 minutes. And it's also painless too. And I should mention that, yeah, Intacs are painless. And by the way, if you're nervous, we always have Valium to relax you. And it's also usually a 1-day recovery for these procedures. So CK here is using this probe, and the probe actually helps to do some lifting as it improves astigmatism. So we want to put this not in the steep area, but actually in the flat area. So I'm going to show you some topographies here. but we will place this and it causes a little local contraction there, but it causes steepening um, closer to the cornea center. And that's why it helps to improve astigmatism by lifting up the flat area that I'll show you, but then we'll follow with Holcomb C3-R because we need that cross-linking to lock in the effect for the CK astigmatism. So here's some examples. The lower area right here is where this is the pre-mapping, and we put the CK in the blue area. So you see here above, it's not as dark blue, which means it's less flat or more steep. And the difference map shows this astigmatism that we were able to correct by putting it in that zone. So Intacs will go below, for example, in the red, but the CK spots go above, so it's lifting. And here's another example too, where we see the steepening below. So we did Intacs below here, and we put CK, the heat spots in the flat area to help lift it. And up here, you can see again, the blue is a lot less blue. We got that nice lift above, and we got a lot of flattening below. And the difference map shows the subtraction before and after topographies. So we see the effects of that CK. Now, the ICL has been a great addition for people with keratoconus. Why is that? Because with keratoconus, the cornea is bulging. And as the cornea bulges out, it creates more nearsightedness or myopia in the prescription. So as a result, people have really high prescriptions a lot of times with keratoconus. They're very nearsighted. Without their contacts or glasses, they can only kind of see really close because they're so nearsighted. So this is a lens implant that goes behind the iris. So it's inside the eye and goes behind the cornea as well, but it's really resting behind the iris. And this just shows you a cross section. So this white light beam here, that's the cornea on the right. You can see the iris here, and then there's the pupil, and this little sliver is the ICL. It's the cross section of the ICL resting in front of the eye's natural lens. And so it's also painless, again, like a dental filling, kind of like the Intacs 2, where you don't feel it. And we usually, if we treat the keratoconus first with these other procedures, we'll want to wait about 3 months for it to settle and stabilize. And that helps to get us the most accurate, best results when we come back later for the ICL. And there are some cases where the keratoconus is really mild, so we don't need to do Intacs, but there's nearsightedness. So we can actually then at that point do the ICL and Holcomb C3 on the very same day. So yeah, as I mentioned, this is also a painless procedure. It's about 7 minutes with a 1-day recovery. And of course, if you're nervous, we have Valium. If what we've been discussing has been resonating with you, then I'd recommend to schedule a brief 15-minute Q&A call with my assistant to have all your questions answered relative to your specific case of keratoconus. And when you do that, we will send you a complimentary copy of these 3 books. And the most recent one is about my TEDx talk that I gave for keratoconus called Fight for Sight and How I Pioneered Holcomb C3-R. Incredibly informative books. And this will be a great next step for you. So the website is a little long. That's why we have a QR code. So just you can take out your phone right now, and just with the camera, it'll bring you right to the calendar to schedule that Q&A session with my assistant.